Cerebral aneurysms are localized dilations of arteries caused by a weakness in the vessel wall. Various factors lead to the development, growth, and rupture of these aneurysms. But for the purposes of this afternoon's lecture, suffice it to say, there's a potential for morbidity, mortality, and significant disability throughout the course of the disease. As a part of the management team, we anesthesiologists will never be there simply to put our patients to sleep. Rather, we're there to safeguard our patients' well being throughout the entire perioperative experience. Good afternoon. I'm Dennis Lopez, and I will be discussing the anesthetic management of patients for cerebral aneurysm surgery. This afternoon, we aim to discuss the effects of ruptured cerebral aneurysms. We then proceed to enumerate the goals in the management of patients with cerebral aneurysms. Next, we describe essential and hopefully available monitoring tools for patients undergoing surgery. We will also be discussing anesthetic techniques and goals for patients, and then focus on the goals and management of an intraoperative aneurysmal rupture. To start with, here are a few concepts. The Monroe-Kelly doctrine states that the cranium and its contents create a state of volume equilibrium, such that any increase in the volume of one of the cranial components must be compensated by a decrease in the volume of another. This can be illustrated in this elastance curve, wherein minimal increases in pressure occur in the initial phases due to intact compensatory mechanisms such as CSF and venous shunting. With further volume expansion in the intracranial space, these compensatory mechanisms become exhausted to the point that there's a steep rise in pressure for incremental volume changes resulting in intracranial hypertension. Cerebral perfusion pressure, or CPP, is the net pressure gradient that causes blood flow to the brain. A definition of CPP is shown in this formula: mean arterial pressure minus intracranial pressure. Intimately related to this is the transmural pressure inside the aneurysm. While both TMP and CPP are determined by the same equation, MAP minus ICP, a tricky balance exists wherein we want to maintain adequate cerebral perfusion while minimizing TMP to prevent rupture. Any conditions that abruptly decrease ICP or increase MAP can provide a setting wherein the increase in TMP leads to rupture. Subarachnoid hemorrhage due to a ruptured aneurysm is a sudden, severe thunderclap of a headache, often described by patients as the worst headache of my life. Other symptoms can typically accompany this headache: nausea, projectile vomiting, altered mental status or loss of consciousness, visual changes, focal deficits, and seizures. If left untreated, it starts a cascade of events which can lead to permanent disability, even death. The subarachnoid hemorrhage exerts mechanical effects inside the closed cranial vault, causing ischemic damage and brain tissue destruction due to increasing ICH, its mass effects, and also hydrocephalus. Acute global ischemia ensues due to the compromised cerebral blood flow as a result of increasing ICP and decreased CPP. Acute hydrocephalus can also lead to microcirculatory constriction and thrombosis. Systemic complications also develop due to inflammation, sympathetic nervous system activation, and catecholamine surges. Cardiovascular dysfunction with ECG manifestations are common, with subendocardial necrosis believed to be an underlying mechanism. Pulmonary effects can lead to deficiencies in oxygenation and ventilation. This table shows a summary of complications resulting from aneurysmal SAH, which may greatly influence anesthetic management. Patients referred to us may present with a myriad of these signs and symptoms. Further investigation and optimization prior to surgery is essential, inasmuch as time allows prior to definitive surgical management. In addition to the usual preoperative evaluation, one should place extra focus on the aforementioned clinical manifestations due to the ruptured aneurysm. Reviewing the vital signs from admission to referral enables us to determine compensatory mechanisms at play and the level of homeostatic reserve that our patient has in terms of being able to maintain adequate cerebral perfusion. The neurologic exam and grade presents as our baseline comparison for the patient post-surgery. At this time, we are usually already part of a multidisciplinary team whose goal is to prepare and optimize the patient prior to surgery. Cardiopulmonary manifestations are investigated to determine whether they are part of a syndrome of SAH or as concurrent comorbid problems that are aggravated by the current pathology. Ongoing treatment and ancillary laboratory values may also affect our anesthetic management plan. Electrolyte abnormalities are often present, such as hyponatremia and hypokalemia. Fluid deficits are also common. Hypovolemia increases the risk of cerebral ischemia, especially in the setting of vasospasm. In preparation, one must also consider the need for blood transfusion in order to improve a patient's oxygen carrying capacity and correct any bleeding diathesis. A proper preoperative visit should be enough to allay any patient concerns. Significantly anxious patients may become hypertensive, leading to a greater risk for rebleeding. Pre-medication should be individualized and used judiciously, as some of these medications, like narcotics, can cause respiratory depression, leading to increased cerebral blood flow and cerebral blood volume. Prior to induction of anesthesia, we prepare standard ASA monitors and place them on the patient. It is important to set your patient's parameters for each of these monitors and to maximize the use of alarms for closer monitoring. We place an ECG to monitor arrhythmias, an NIBP for a target map within 20% of baseline, especially for patients with impaired cerebral autoregulation, a pulse oximeter, an end-tidal carbon dioxide monitor is essential too, especially since manipulation of ventilation is used to manage changes in ICP. Determining the actual minimum alveolar concentration levels of patients is important when volatile anesthetics are employed. Monitoring for neuromuscular blockade, urinary output, and temperature are also important. Monitoring for aneurysm surgery should also include direct intraarterial BP measurements, preferably instituted prior to induction of anesthesia. The arterial transducer should be placed at the level of the base of the skull to accurately reflect the cerebral perfusion pressure. Intraarterial access also allows blood sampling for the determination of hematocrit, blood gases, glucose, and electrolytes, among others. Both hypoglycemia and hyperglycemia can exacerbate cellular injury during cerebral ischemia and has been associated with poor outcomes post-surgery. We aim for a more liberal range of blood glucose, as opposed to tight glycemic control, which has shown greater incidence of hypoglycemic episodes. Again, please take extra time to set your parameters for monitoring and maximize those alarms. Preparation also includes providing large bore intravenous access for fluid resuscitation, blood transfusion, and administration of meds and infusions. Central venous catheters may be inserted in some patients for guidance of intravascular volume and administration of potent cardiovascular drugs and mannitol. Cardiac compromised patients or those with severe vasospasm may benefit from cardiac output and pulmonary capillary wedge pressure monitoring, although there are less invasive methods that can provide similar information. Vasoactive medications are prepared apart from the anesthetic agents for a more precise control and regulation of MAP and CPP. Optimal airway equipment for smoother induction and intubation are also on hand, even if a difficult airway is not necessarily suspected. Decreasing the volume of CSF using a lumbar subarachnoid or ventriculostomy catheter is an effective means of reducing brain bulk and may be necessary to achieve satisfactory brain relaxation. Listed here are the general goals for anesthesia when managing cerebral aneurysm patients. Provide optimal conditions for surgery, to maintain adequate cerebral perfusion, to avoid acute increases in transmural pressure, and to enable prompt neurologic assessment of the patient post-surgery. Intraoperative management is a team effort. On either screen may be a physical partition, but it shouldn't be a barrier between the surgeon and the anesthesiologist. Each should be able to freely communicate their concerns. Anesthesiologists need to understand the requirements of the surgery and integrate those needs into their plan. Craniotomy access depends on the location of the aneurysm. Placing the patient in the optimal position requires that the airway be secure and unencumbered. Unimpeded venous drainage and adequate arterial supply are taken into consideration during head turning and elevation. The more critical parts of the surgery need to be discussed as well. Again, communication with the surgeon is the key, especially since one does not often have a direct view of the operating field. One needs to prepare and anticipate the possibility of a rebleed, evaluate the extent and impact of intracranial hypertension, as well as plan for the possibility of aneurysmal rupture, the use of temporary arterial occlusion, or hypertension. Post-operative patient disposition, concerns, and monitoring requirements need to be discussed as well. Providing a slack brain is useful in that it decreases the risks for brain tissue ischemia due to retraction. Various methods may be employed with this goal in mind, but brain relaxation methods are not without their risks. The use of osmotic agents or aggressive drainage of CSF prior to dural opening may lead to an increased TMP gradient and risk for rupture. Excessive hyperventilation and its resultant hypocarbia can result in cerebral ischemia due to arteriolar constriction. The aforementioned methods are also helpful in providing adequate surgical exposure. Maintaining adequate cerebral perfusion is paramount. This enables oxygenation and substrate delivery to brain tissue, especially to already compromised areas of the brain. Recalling and understanding the formula of CPP can help us with this goal. On the MAP side, this can be achieved via augmenting forward flow to the tissues. We aim for euvolemia via adequate hydration and maintaining intravascular volume. Anticipation of intraoperative fluid shifts and losses has been mentioned earlier, as well as planning for transfusion of blood and blood products. In certain instances, vasopressors or inotropes may be employed to aid in this augmentation. Methods to decrease ICP can also help or maintain or improve CPP. Aiming for hypocapnia via hyperventilation can cause a transient decrease in ICP due to a resultant decreased cerebral blood volume. That is, until the buffer mechanisms in the CSF kick in. However, aggressive and sustained hyperventilation may lead to cerebral ischemia and is not recommended. Next, we want to avoid acute increases in the transmural pressure gradient. Sudden increases in TMP may lead to rupture. Particularly vulnerable periods during anesthesia occur during laryngoscopy, head pinning, incisions, or any other forms of sympathetic stimulation. As mentioned earlier, we aim for a balance between maintaining cerebral perfusion and avoiding acute increases in TMP. To this end, establishing intraarterial access prior to induction helps immensely. The utility of moment-to-moment monitoring of MAP allows us to promptly deal with any blood pressure lability. In the immediate post-op period, we should be able to assess whether the patient's recovery is satisfactory and consistent with the anesthetics given. During this time, we aim to distinguish anesthetic and surgical complications and institute early intervention when necessary. The preoperative condition, anesthetic medications given, and intraoperative events are all taken into consideration. The choice and preference for induction and maintenance is based on the ability of the chosen agents to provide hemodynamic stability and avoid increases in ICP. No single technique or medication is superior, and we aim for balanced anesthesia. This table shows common agents we use for induction and maintenance and their cerebral effects. Analgesia during stimulating portions of the surgery may be provided through judicious use of opioids. As adjuncts, local anesthetics are also often employed, from the use of IV lidocaine to blunt the hemodynamic responses to intubation, to the local infiltration at pin clamp sites, or administration via scalp block, whose effects may provide an additional anesthesia post-op. Neuromuscular blocking agents are used to facilitate endotracheal intubation and akinesia throughout the surgery. This patient movement can be catastrophic. Non-depolarizing neuromuscular blocking agents are commonly used unless a rapid sequence induction or difficult airway management is anticipated. While non-depolarizing neuromuscular blocking agents have no direct effects on cerebral physiology, we prefer to use non-histamine releasing agents because of their potential to decrease MAP and CPP due to their vasodilatory effects. In reality, factors such as availability of meds and equipment, along with the level of comfort and knowledge of the attending, may influence approaches and outcomes. Adhering to clear and achievable goals provides a good roadmap in dealing with these patients. Application of skull pins is a highly painful but transient stimulus. Comparable to intubations and skin incisions, it results in sudden hypertension and tachycardia, which increases the TMP and the risk for rupture. Again, the goal for this is adequate analgesia and adequate depth of anesthesia. In certain instances, surgeons will need to apply a temporary clip on a feeding artery proximal to the aneurysm to facilitate dissection. However, this maneuver creates an area of focal ischemia, leading to poor neurologic outcomes with increasing occlusion time. In order to mitigate this, increasing forward flow by MAP augmentation and collateral recruitment is performed. Neuroprotective strategies have also been investigated to mitigate the effects of this ischemic event. Drugs such as propofol or barbiturates can be used to induce burst suppression in affected brain tissue, leading to decreased metabolic requirements. Concomitant decreases in MAP need to be managed to ensure adequate cerebral blood flow and perfusion. Despite this, pharmacological neuroprotection does not have sufficient data to support its routine use. There's still no magic bullet. A decrease in CMRO2 also occurs during hypothermia. However, studies have shown that induced hypothermia was not associated with improved outcomes in patients who underwent temporary arterial occlusion. Historically, controlled hypotension methods have also been used to achieve similar goals as temporary occlusion. In certain instances, this may still be employed. This table summarizes significant differences between the two. By far, the most dreaded complication is intraoperative aneurysmal rupture due to its potential for significant morbidity and mortality. This may occur during conditions that promote increases in TMP, as previously described, or during direct manipulation. During dissection and clipping, we aim to decrease TMP in order to reduce aneurysm, neck, and wall tension, thus facilitating clip placement. In 2018, the Society for Neuroscience in Anesthesiology and Critical Care, or SNAC, published guidelines for neuroanesthetic emergencies, one of which tackled intraoperative aneurysmal rupture. First, we have to appreciate the various etiologies of intraoperative aneurysmal ruptures. We've discussed goals related to control of MAP, TMP, and cerebral perfusion. Depending on the timing of rupture or stage of surgery, the clinical presentation may vary. It can present as sudden hypertension followed by bradycardia and a Cushing-like response, while arrhythmias, brain bulge or hematomas, or bleeding from the surgical site may also be the presenting sign. Following this, our initial goal is to stabilize the patient prior to definite treatment. Communication with members of the operating staff regarding anticipated blood loss and surgical visibility is important. Next, we ensure that adequate intravascular volume and flow is maintained using fluids and vasopressors. We increase FiO2 as needed and consider transfusions to maximize oxygenation. Depending on the timing of rupture and stage of surgery, treatment may vary. If the rupture occurs before dural opening, these maneuvers may be employed. Abrupt increases in ICP are controlled with modest hyperventilation. Immediate BP control is recommended. Another goal would be to minimize the CMRO2 using IV anesthetic agents such as propofol or barbiturates, still with the caveat of their effects on MAP. The immediate surgical goal will be decompression, and this may be facilitated by osmotherapy with mannitol and hypotonic saline. If the rupture occurs after dural opening, usually during aneurysm dissection or clip placement, the overall goals are still similar. The anesthesiologist may be asked to transiently and acutely reduce MAP to decrease bleeding, improve visualization, and soften the aneurysm neck for clipping. Transient flow arrest can be employed or requested for precisely the same goal, usually for giant aneurysms. Similarly, decreasing CMRO2 lessens the metabolic requirements of affected and potentially ischemic areas of the brain. Of note, hypothermia is not recommended regardless of Hunt and Hess grade. Vasospasm and delayed cerebral ischemia is a significant cause of morbidity and mortality. Of patients in whom symptomatic vasospasm develops, approximately 50% die or are left with serious neurologic deficit. Vasoactive substances found in blood in the basal cisterns induce inflammatory changes in the cerebral arteries to cause severe constriction. Symptomatic patients may present with decreased levels of consciousness, new onset focal deficits, and mutism. The Triple H therapy has been the cornerstone of the management of vasospasm. Each of the components ostensibly act in conjunction to improve blood flow through narrowed vessel via increasing perfusion pressure and decreasing blood viscosity. However, hypervolemia and hemodilution are associated with significant side effects and do not significantly improve local cerebral oxygenation. Current recommendations advocate hemodynamic augmentation with hypertension and euvolemia. Typically, patients with low-grade clinical presentations who underwent uncomplicated procedures are allowed to awaken and may be extubated. For patients with higher-grade aneurysms, the same considerations of early assessment and intervention may still apply. However, poorer-grade aneurysm patients are generally kept on ventilatory support and committed to continuous neurointensive care monitoring. Patient recovery following anesthesia is affected by pre-op neurologic status and assessment of the effects of significant intraoperative events. Again, we go back to goals that can guide us during this assessment. Have we established and maintained adequate cerebral perfusion? Were intraoperative losses replaced? Are there significant residual anesthetic effects, especially muscle relaxants? Is our patient able to maintain a patent airway, resulting in adequate oxygenation and ventilation? Are there new deficits that require further evaluation, intensive monitoring, and urgent management? This evaluation also informs our decision on whether or not to extubate patients or to commit them to mechanical ventilation and neurointensive care monitoring post-op. All our actions have consequences, some more enduring than others. Ultimately, we aim to help our patients recover. Let's make the moments with them matter. Thank you.